All right, good morning, everybody. It is the 21st of August, and today we are meeting to go over our ROB2 or ROB2 for record 2,905. First and foremost, is there anybody who was not able to bring up onto their computer the four documents that I have instructed us to all bring up in the chat? Those would be our own Rob2 for 2905, the long instructions for performing the Rob2, everybody else's Rob2 for record 2905, and record 2905 itself. Everybody has all four of those items up and ready to go?
Yes.
Yes.
Yes. Very good. Excellent. I like the progress there. So everybody who's here is going to take turns leading, which is just going through step by step what everybody did, because this is group participation. Because as far as I know, there's not one. I don't even think there's a way for one person to do it exactly correct, because it is a matter of interpretation here. So input from everybody is going to be highly encouraged. Now, I want to just ever so briefly go over some key concepts from this record, because if you haven't got your medical degree yet, a little bit of it may be confusing. And before we start getting into the risk of bias, I just want to make some very important clarifications, because some of it can be medically complex. Okay, so this is the randomized comparative trial of indomethacin and Solindac, which I'm actually not very familiar with Solindac, so I had to learn. Indomethacin, of course, for the treatment of refractory preterm labor. So the indomethacin, I'm very familiar with it. At this point, which this article was from the 90s, the indomethacin was actually the control, because that was the standard of care for tocolysis. So tocolysis is the halting of labor. So in this case, these women were having preterm labor and they wanted to stop it. And so they were using the NSAIDs. Typically the ones that is used is indomethacin, but for the purposes of this experiment, they were also utilizing the Solindac, which is Sulindac. So to be clear, the indomethacin was the typical standard of care at this time. Okay, so now that we have that established, I want to explain some tricky facts, because there's a lot of double negatives occurring here. So prostaglandins do a lot of things, and there's a lot of different types of prostaglandins, and they do different things on different organs. So the three most important things for you to know about what prostaglandins do for the sake of interpreting this trial is, one, it keeps the ductus arteriosus open. And so if a prostaglandin is inhibited by an NSAID, that would just function. Then this is just very superficially, very plainly. Of course, there's nuance and you could really dive in, but just for the sake of clarifying the double negatives here, I'm going to just be very general and say that NSAIDs would close the ductus arteriosus. Okay, so prostaglandins keep it open and NSAIDs would shut it. And so if we have before birth, we have an open ductus DA, so we'll just say DA, and after birth it closes. So if everybody here, you have a closed ductus arteriosus, okay? And then the other thing is prostaglandins keep the blood flow going to the kidneys, the baby's kidney. And so if the baby has NSAID on board, it could decrease the blood flow to the kidney, which would result in less urine output by the fetus, which would result in less amniotic fluid, which would result in something called oligohydramnios. And so there's just a lot to to remember, because one thing does another. And so just to summarize again, the first thing was the NSAID affects the ductus arteriosus. It would make it shut. And then the second thing is the NSAID could decrease the urine output and leads to low amniotic fluid, which is oligohydramnios. And then the third thing is that prostaglandins particularly E and F, facilitate things that would result in delivery, contractions, and what have you. And so, halting the prostaglandins in that case, which is the whole point of what's going on here, the NSAID, would function to delay the onset of labor. And they're trying to delay the onset of labor in these women because they're going to labor too soon. Okay, so the three things that the prostaglandins, and subsequently, because NSAIDs affect the prostaglandins, would be the ductus arteriosus, the fluid and urine output and amniotic fluid, and then contractions. Okay, so those are the three things that we're playing on here. It's really important. So the treatment that they're trying to do is tocolysis, which is to stop the contractions. Okay, now the way that they evaluate these results, or these the, I suppose, end effects here, is a little bit confusing. You have to know physics a little bit, because whenever you first see that one of the things that they're assessing is the velocity of the flow through the ductus arteriosus increases, and actually, so the diameter of the thing that it's going through actually decreases for the velocity to increase. So how do I explain this? So basically, higher velocity means more constriction, more closure. You may, if you don't have a great grasp of physics, you may think, oh, the higher velocity, it must be open more. But in fact, when they found the higher velocity is more constriction, and that's kind of a tricky thing. I just wanted to point it out. I'm trying to get through this so fast because there's a lot of tricky things. um so, well, speaking of the different um areas that we are assessing, so the outcomes. So before we go, what we need to do is decide which outcome we're going to start with first, and review. If we all look at everybody's, like, the everybody's submissions, so there's Abigail, Samiha, Gloria. I don't know video. I don't know what that one's about. Abigail has another one. Um, so it looks like almost everybody submitted theirs, but what is not consistent is what outcome. So some people only did RB2 for one outcome, and some people did them for 24. I actually got, how many outcomes did I do? I found that there were 13 outcomes. So can we all go take, and it's not necessarily wrong or right, because actually number 5 of my outcomes I had just put as maternal side effects because they weren't specific. So I'm not saying that there's a right or wrong answer to this, but could we just go through each person and say how many outcomes we assessed for? So my answer was 13. I found 13 outcomes. Let's go in alphabetical order so that we're not wasting time saying, oh no, you go first, or no, you go first. So alphabetical order by first name, and then you can actually go to participants and see everybody is in alphabetical order by their first name. So Abigail, and then our guests, and then Gloria. Abigail, you're first.
I did 23 outcomes.
23 outcomes. Okay. And then Dr. Tahana and Mr. David, how many outcomes did you get? Mr. Riviera?
Hello.
Hi, hi. How many outcomes did you assess for in the ROB2 of record 2,901
We assessed one outcome.
outcome? Okay, one outcome. So we have 23 of one. Gloria, you're next. How many outcomes did you assess?
I think I got 26.
Mhm. All right, next.
I think I
Um,
got,
Jordan would be by
I'm sorry.
after Gloria, right? In alphabetical order.
yeah, I got 11.
Jordan.
Yeah, I got 11.
11. Okay.
I got 19.
19.
I think I got around 20.
20. All right, so we have a varying amount of outcomes. And mine seems to be right in the middle at 13. So Dr. Tahada, and Mr. David. Now, my understanding is that you have actually professionally performed a Rob2. So would you enlighten us as to why you did one domain and did we all do it incorrectly by doing so many domains?
Hello. Yesterday, when we were trying to do the exercise of evaluating, I think we misinterpreted the directions because we just took the main domain, which was the delay uh, of the preterm birth, and we evaluated just one domain.
Okay. Yeah, so the actual thing that they were trying to assess is, I think that it was pretty much assumed that they would both have similar effects on delaying the preterm birth, but it looked at which one had more side effects. So the purpose of this randomized trial was to evaluate the safety and efficacy of Sulindac when compared to endomethacin for tocolysis of refractory preterm labor. So both NSAIDs did their job, which was to delay preterm labor. But then there were so many other things that were affected, like the baby's urine output, and I found 13 of them. So I have urine output, I have the amniotic fluid index. First I had the amniotic fluid pocket, and then I had the amniotic fluid index. That was 2. For 3, I had urine output. For 4, I had the flow through the ductus arteriosus. For 5, I had the maternal side effects, and then 6 through 13 were the items listed on table 4: birth weight, APGAR score, umbilical artery, days in the NICU, number of days on the ventilator, patent ductus arteriosus, interventricular hemorrhage, primary pulmonary hypertension was my 13th one. So again, I don't have any publications in which I have actually conducted ROB2 assessment. So I wouldn't say that I'm an expert at this. So let's see, Dr. Tahada, when you have done this in the past, have you only assessed the outcome for the actual thing that they're treating for? Do you think that we're in error to do a Rob2s for each of these domains that I just listed, the 13 that I just listed? And while we're waiting for a reply, would you all like to look, since you have access to everyone else's Rob2, would you like to take a moment to see, since we obviously need to pick one to start with, do you guys want to look at everybody else's and see
Hello.
if we could perhaps start with the amniotic fluid pocket? Yes, hello.
Answering to your question, I just start with Dr. Tejada. We evaluate all of the outcomes, all
Okay.
of the interest outcomes from everyone of the study. For the manuscript, it's presented the main outcome, but the evaluations of the rest of the outcomes are put in supplementary materials and published alongside the the manuscript of the systematic review.
Okay. Well, for our systematic review, we are doing our OB2 assessments on, someone tell me how many articles? So we're doing risk assessments, risk of bias assessments on how many someone answer, and then how many of those are RTCs, and of which we're doing Rob2s. Probably Abigail would have the numbers on that.
There are a little over 250 RCTs.
Okay, so we have 250 randomized controlled trials. So pretty much everything is going in our appendix because we don't have the room to squeeze very much into the actual. It's a very enormous review. But for the sake of our figure in our actual publication, I think it's just going to say whether this record number had low, some, or high risk of bias. But I guess I should have also added a 14th one, which would have been, yeah, I should have done a 14th one, which is what they were actually studying to begin with, which was the delay of labor. So we have to pick some outcome to go over together as an example. And moments ago, I had asked if pretty much everybody had done an ROB2 for the fluid pocket one. Is that a good example for us to? Well, I guess since our guests did. Let me back up. Since our guests did the outcome for the delay in delivery, students or a research team, did you also do an outcome for delay of delivery? So if we were to do that as our first example outcome, would everybody be able to follow along? I'm going to need a yes or no from each of you because I can't read minds, right?
I did not do an ROB2 for the overall success of the tocolysis.
All right. How about everybody put in the chat yes or yes if you did an ROB2 for the success of the halting of the premature labor, aka efficacy of the tocolysis. No. I wonder why none of us thought to do that. Maybe we just assumed that we kind of already knew that it did do that. Well, we shouldn't assume anything. That's not appropriate. Let me just get into the chat. Yes, I did all of the outcomes. Okay. Listed under oh wait, actually, was that already one of them? All the outcomes listed under table 2. Oh yeah. And oh, that's why you got so many more than me. That would make sense. All right. Okay, Critica, you also had the tocolysis as an outcome that you assessed for your Rob2.
Yeah.
Okay. Well, that's good because my understanding is that you and Abigail are both formally doing this. So, perfect. Okay, so I believe that we have enough people that have done the ROB2 for the main outcome, which is the tocolysis. So we have Abigail and our 2 special guests, and Critica and Lydia. Did I miss anybody who did a risk of bias assessment for tocolysis? Did I name everybody?
I did all the outcomes under table 2 as well.
Okay, good. Okay, so plenty of people did that. So we are going to start off now with going through each domain with the first outcome, which we will designate as success of the or failure of the tocolysis. Does that sound good to everybody?
Yes.
Yes.
Just to repeat what I said is now that we're all on the same page here. We are about to start. We're going to go through in alphabetical order, each person leading, going through your own sheet. The Rob2 based on the outcome of tocolysis. Yes, let's go alphabetical order. That would be Abigail first. So just lead the way, go through each box, ask everybody what they got, and then every 15 minutes we will switch. And I would love for our special guests to interject because my understanding is that they have much more experience in risk and bias assessment than the rest of us. So I invite you to interrupt us at any time. Dr. Tejada and Mr. David, do you understand that I highly encourage you to interrupt us and clarify things? Because we appreciate your time and we want to extract as much knowledge from you as possible.
Yes, of course, we understood clear.
Okay, very good. All right, Abigail, let's get started.
Okay. The first outcome that we can go over is contraction frequency at 2 hours.
And would you
Um,
like to share your screen so we know what you're reading from? I mean, we all have our own template, but I just think it would be helpful to have a visual. You know, you can read like domain 1.1 and that sort of thing and have that on your screen
Yeah.
rather than us just looking at the person, the invisible person.
It's saying that the host has to allow me to share.
You should have all powers in the Zoom call now.
Okay. Okay, so for the first outcome, we will do contraction frequency at 2 hours, and the exact result would be the one listed under table 2. Does everyone agree with that?
Yes.
Yes.
Okay. And then is the review team's aim for this result to assess the intention to treat effect or the per protocol effect?
Intention to treat.
Mm-hmm. Okay. Since we went with intention to treat, we don't have to answer the next question. And then which of the following sources were obtained to inform the risk of bias assessment? It'll be the journal. And did everybody get this as well?
Yes.
Okay. For domain 1.1, was the allocation sequence randomized? What are your answers?
I know I put yes.
I also put yes.
Okay. Can you tell us why?
I particularly put yes because the each participant in the study was randomized and there were sealed envelopes to receive either the indomethacin or the Solindac, but
That's also what I had.
Okay. Did anybody get a different answer for 1.1?
During the exercise, we answer probably yes, because it is described that the investigators use sealed envelope at the moment of assigning the treatment groups. So if they made the envelopes, it's most likely that they made a randomization. So we answer probably yes.
Okay. I had a different answer. I said NI because the exact method or process was not reported for generating the sequence. But we can vote on it together to decide on 1.1. So those of us who want to go with probably yes, you can just say so.
I would put probably yes.
Probably
Same.
yes.
Me too.
Okay. Okay, so we'll go with probably yes for 1.1. For 1.2, was the allocation sequence concealed until participants were enrolled and assigned to interventions? What did we say for 1.2?
I put no information.
Okay. Did anybody answer it differently for 1.2?
I put probably yes for this one as well.
Same
I put
here.
probably yes as well.
Okay. Can somebody tell me why you answered probably yes for 1.2?
It was mostly the same reasoning as 1.1 with like the randomized by means of sealed envelopes. So it describes the concealment mechanism. But the sealed envelopes, I think they meet like the minimal criteria for adequate allocation concealment identified in the Rob2 guidance. So even though like the extended criteria there it's not described in the text. So I put probably yes for that reason.
Okay. For me, I said NI because when I looked at the guidance document, it does say that the minimal criteria should be opaque, sequentially numbered, and sealed on envelopes, and that's page 13 of the document. But I could be wrong, so we can vote on this one as well.
I put NI just because there was no information about um whether or not the participants were like the allocation sequence was concealed until the participants were enrolled and assigned to interventions. But I do agree that the method of allocation or the method of concealment was adequate.
Okay, so for 1.2, do we want to go with probably yes or NI?
I think Lydia brought up a good point, so I'd put NI.
Okay, does everyone agree with that? Yes, no?
Yeah, I think so.
Okay, so for 1.2, we will go with NI. 1.3, did baseline differences between intervention groups suggest a problem with the randomization process? What did you say for 1.3?
I said no.
No? And does everyone agree with that?
Yeah.
Yes.
Okay, so based on our answers for 1.1, 1.2, and 1.3, would the judgment be low, high, or some concerns?
Some concerns because of the not enough information.
I just,
It'll
sorry to interrupt. I wanted to see, did Dr. Tejada see my message in there that I think it would be helpful since we have everybody else's in front of us, if we could have a copy of theirs that we could all see. I think that would be super helpful.
Hello. Dr. Tejada was just called for a meeting with our director, so he excuses himself, but I will remain during the rest of the meeting. He will try to reintegrate as soon as possible.
Okay, thanks for letting us know. Could we have a copy of your paper? Because we have everybody else's here to look at, but I can't. Is yours here? Can you put it in the chat so that everybody who's on the call can access it, please?
At this moment, he is the one that has the final document that we worked. because we work with all of the comments in his PC. So as soon as he comes back, I will tell him to share it with the rest of you. And on this regard, we were discussing it yesterday. We put low risk of bias because we evaluated like probable yes and probable yes. And when we finally see the distributions in table one of how there is no signs of a bad distribution because of randomization, because all of the proportions are really similar and we don't see significant difference, we assess the risk of variance on this domain as low.
Okay. But Abigail, you have some concerns, right?
Yes.
You're allowed to have concerns. It's okay. Sorry, I only interrupted because I was hoping to see a copy of Dr. Tejada's paper, but please excuse my interruption and get back to what you were doing.
I think he put probably yes for 1.2 for the same reason that we did. Maybe I think he could confirm this, but like the sealed envelope meets the minimal criteria that's in the Rob2 guidance, but the extended criteria isn't confirmed. So that's why it shifts it to like instead of a yes definitive, it's like a probably yes. But I'm not sure, like you could correct me on that.
Yeah, so if everybody goes to the other document that I wanted you to have up, that one, if you go to page
It'll be 13.
well, heavens, I put the page number somewhere. Yeah, so domain one, in the document that starts 20190822, domain one is discussed on pages 10 through 21. So if you go, not that, yeah, pages 10 through 21. Was that Avni that was talking? I'm sorry, I didn't say who.
Oh, it was me, Kritika.
Okay, Kritika. Okay. All right. So if you guys need to, actually, maybe you want, just for your future notice, domain one is discussed on pages 10 through 21. Domain two is discussed on pages 21 through 39. Domain three is discussed 39 through 49. Domain four is discussed from 49 to 58. And domain five is discussed from page 58 to 68. Okay. Sorry, please go back to what you.
Okay, because when we look at the full guidance document on page 13, there's a table, it says table 2, and then it provides you with a minimal criteria for judgment to answer 1.2. And for sealed on envelopes, it does state that it needs to be opaque and sequentially numbered. And since for this paper they don't specify that, I wasn't sure if they did in fact conceal the allocation sufficiently.
Yeah, I guess technically it could have been a clear envelope. I mean, it's doubtful, but you can't jump to conclusions here. All right, I swear, this is you guys leading. I'm not talking anymore. Abigail, go ahead.
Okay, so based on what we discussed, should we change our answers for 1.2 to probably yes or stick with NI just to be on the safer side?
I think that since they didn't report tampering or foreknowledge of the envelope, or that they didn't tamper with the envelope, like anywhere in the article, they just didn't report it. We can't assume that they didn't tamper with it, if that makes sense. So I think NI would be the safer option.
I agree with that. Okay, so we'll keep 1.2 as NI, which will keep the judgment as some concerns, and we're all agreeing on that.
Yes.
Yes.
Okay, we'll move on to domain 2. And for domain 2, we'll be completing the one for the effect of assignment to intervention. 2.1, were participants aware of their assigned intervention during the trial? What did you say for this one?
I put probably yes.
Probably yes. Okay. Did anyone have a different answer for 2.1?
I said NI because there was no explicit statement about blinding of the participants.
Okay.
I thought I found in here that they were. The participants were blinded, but the investigators weren't. I could be wrong. That's what I thought I read. Someone may interject.
I personally couldn't find a statement about the participants being blinded, but I could be wrong as well. So
I also didn't find anything.
Yeah, I
about that.
did.
I also
We
didn't
found
find
that,
anything.
like,
Give me a
We
minute.
also assess as non-information because we couldn't find any statement about the blinding of the participants. So we left NI.
okay. I said probably yes, and the reason is because the two treatments had different dosing schedules, and so it'll be easier for the participants to figure out which treatment they were taking based off of that.
That was
Did
also my reasoning.
And that makes sense. The thing I was looking at was at the bottom of the second page where it talks about the investigators were not blinded as to the group assignments, but I don't see anything one way or the other regarding the participants. So, yeah.
Okay, so for 2.1, do we want to go with probably yes or NI?
NI.
NI.
Okay. So for 2.1, we'll say NI. 2.2, were carers and people delivering the intervention aware of participants assigned in intervention during the trial? What did you say for this one?
I said probably yes.
I also said probably yes.
Okay, did anybody have a different answer for 2.2?
I also put no information for 2.2 as well.
Okay. Can you tell us why?
I referred back to the fact that there's no explicit statement about blinding of participants along with like the carers. But I also noted that the principal investigator was not blinded to the group assignment.
Do we
Okay.
know if the principal investigator performed any of the carer activities, or do we just not know that one way or the other?
I don't think we know that.
Just to the paper states that the principal investigator was the one who did all the scans, all the image scans, and he was the one that searched through the patient's records to see if they had any adverse effect. So the investigator was not the one caring or delivering the interventions, but he is later in the exercise when in another of the domain they ask if the person who assess the outcomes knew the intervention group. So our interpretation was that the investigator was not among the people delivering the intervention, but he was the one assessing the outcomes.
I agree with that, but can we make an assumption if it doesn't explicitly say that the primary investigator had no part in providing the NSAIDs? I
In
guess the
this
question is, how much of an assumption are we allowed to make?
in this regard specifically, we also put no information because we really don't know if the groups, neither of the participants or the caregivers were blinded. So in these questions, we both answer and no information for both of them.
I have a question. Wouldn't the fact that like the participants taking one of the medication every 12 hours versus 4 hours like hint to the participants as and the people giving the drugs which treatment group they were randomized to?
But since there is no information about the blinding, there's also no information if they did something to conceal the different doses. Like if they did a method to conceal the different hours, like for example, any measure that they did to conceal this difference in how the drug were administered. We really don't know. They don't give any information about any of this aspect.
Makes sense. Okay, so for 2.1 and 2.2, are we going with NI?
Yes.
Okay. 2.3, were there deep deviations from the intended intervention that arose because of the trial context? What did you say for 2.3?
I said NI again for 2.3 as well.
Okay.
I said probably no.
Okay. Can you tell me why, Gloria?
I just said probably no because like they didn't report anything about it. So I guess like I kind of assumed that there wasn't any deviations.
Yes, I also said that. For Critica, can you tell me why you said NI?
I put that there were no specific non-protocol interventions, contamination, or co-intervention differences arising that were like described. And since they didn't like explicitly say that there were no deviations, I didn't want to assume that there were none because I don't think it like said that, like they didn't say it in the paper. So I just put no because it doesn't like provide enough detail to confirm whether the presence of such an effect would occur.
Okay. Um, so for 2.3, do we want to go with no, probably no, or NI?
I would say NI.
Okay, does everyone agree with that?
Yeah, I agree with that as well.
Okay, so we'll go with NI. Which means we don't have to answer 2.4 as well as 2.5. For 2.6 was
Well, it's
an
Gloria's
benefit.
turn because
Oh,
15 minutes is up.
okay. How do I make her the host?
I sent you a request to share screen. I don't know if you got it.
Um, okay.
Okay, let me try. Okay, I think it works. Can you guys see my screen?
Yes, we can
Yes.
see your screen.
Okay, so I think we're on 2.6, right?
Yes.
Okay, so for 2.6, what did you guys get?
I got yes.
Okay,
I
that
put
is what
yes
I
as
got
well.
as well. Did everybody get yes? Did everyone get a different answer?
I also put yes.
Okay, if everyone got yes, then we don't have to answer 2.7. Originally I put low, but I think we changed a lot of our answers for it. So, let me check the thing. I know we put like NI for, okay, so we put NI for 2.1 and 2.2, right?
And 2.3.
Okay, yeah. Um, I think there'd be some concerns then for domain two. Does everyone agree?
Yeah.
Yeah.
Okay. And then for domain three on the missing outcome data,
Wait, can
I
we see if our special guests, Mr. David, do you agree with the final decision on domain 2?
On domain 2, because of the no information in the blinding process, we judge as some concerns.
okay, yeah,
Okay, thank
that's
you.
what we got as well. Okay, so for domain three on the missing outcome data, what did you guys answer for it?
Said yes.
Me too.
I put yes as well.
Okay, that is what I put as well because they said that no randomized patients were excluded from the analysis for this result at least. And since we answered yes for 3.1, we wouldn't have to answer any of the questions for 3.2, 3.3, and 3.4. So I got risk of bias judgment as low.
Me too.
I agree.
Okay. And then
We
for,
agree.
Mr. David, you got low as well?
Yes, we agree.
okay, great. For domain four on 4.1 for the measuring of the out was the method of measuring the outcome inappropriate? What did you guys answer for it?
I said NI for that one.
Yeah, I said not enough information.
Yeah, I put NI as well.
Okay, I actually put N for it. I'm not sure. I said that it was, I think I probably assumed that it was assessed by counting it. So actually, I probably agree with NI then.
Why don't we all define what method this? Okay, first of all, someone say what outcome we're currently talking about, and then somebody else say how it was measured.
We are currently on contraction frequency 2 hours as the outcome.
Yeah, and then I think we put NI because there was really not a lot of information that told us how it was measured in the method section.
Sorry, my internet kind of cut out. Do you think you can repeat that?
Yeah, I think we put NI because there was not enough information in the method section to kind of say how they were measuring it.
Okay, yeah. I think I probably just assumed that it was counted normally, so I probably agree with NI. Actually, I don't know where the rest of my thing went. I need to like pull it up.
Does anybody know how contractions can be measured?
I thought it said in the paper that contraction frequency was recorded directly from a
A to
togodyn.
Yes,
I don't know how to pronounce that.
that's right. You could, one way to assess contractions is just to ask the woman, are you having a contraction? Because it is a certain sensation in your body, a uterine contraction, and they can say yes. But another one is a tachometer or a tocodinemometer. It's just said TOCO. It's a tocodinemometer or a tocometer or a toco. It's a machine. You stick little circles on the woman's belly, and the machine will tell you if a contraction is occurring. So hopefully that clarifies things in case anybody here has not had a contraction before.
I think on page 224 under materials and methods, it mentions that that contraction frequency was recorded directly from like the Toco dynamometer. But if someone else could confirm that, because I just looked over the paper again because I originally had NI.
I wasn't able to find that. Do you remember which paragraph it's on?
Yes, one sec. It it doesn't describe the measurement device or tool. It just says the definition is objective and standard. So I don't know from that if we should assume that it was like appropriate. And since the standard, I guess, is the Toco dynamometer, that was my like line of reasoning for that.
I would say either asking the woman if she's having a contraction or having the toco tell you is both sufficient to determine if a woman is having a contraction or not. It's not really like up in the air, mysterious thing. I think it's pretty definite, no matter which one of those ways you use.
Yeah, I think I agree. Like I I don't think there's a way you can measure like contraction frequency that's like inappropriate. So I kind of just like assumed that it would be like they would use like a method that was objective. I'm pretty sure I think they talked about like the definition and it was like pretty objective.
Yeah.
So what do we want to answer for this one? Like, NI, no, probably no.
I would say probably no for this, maybe,
I
since it
would,
wasn't like directly stated.
Yeah, me too. That's
yeah,
what
I'd
I
have
had
to
thought.
agree.
Yeah, I think probably no might be a better answer for this one. Okay. And then for 4.2, could the measurement or ascertainment of the outcome differed between the groups? I answered probably no. What did you guys answer?
I also said probably no.
Me too.
Okay, great. For 4.3, were the outcome assessors aware of the intervention received by the study participants? I answered yes for this one. What did you guys answer?
I put
I
yes as
also
well.
said probably yes.
For this one, I had said NI, and then I also mentioned that there's no specification of who exactly assessed contraction frequency, because I believe the primary investigator, although he was not blinded, I don't think he was assessing contraction frequency.
Yeah, I get what you're saying. I said yes because the study explicitly stated that the investigator was not blind to group assignment. So, and then I guess when they mean by investigator, whoever was doing all the measurements. So that's why I put yes.
Mr. David had pointed out earlier that this primary investigator was using an ultrasound, so they were explicitly noted to be doing that. But we don't know, did the primary investigator also, were they the person that put the tachometer on the woman? It doesn't say one way or the other.
Yeah,
Mr.
that
David, would you
There
like
is a
to jump in?
part that says that all of the scans were did by the primary investigator. So that's why we interpreted that he was also a part of this assessment, and that's why in this question we answer yes, because it specifically states that the investigator was not blinded.
Well, it says that he did the ultrasound scans, but an assessment of a contraction using a tachometer is not technically a scan. It's um, a sticky circle that you put on the abdomen of a pregnant person, and a little piece of paper prints out with some squiggly lines on it. So if we're going to get really into semantics, I wouldn't consider the assessment of a contraction using a tachometer a quote scan quote. Does that make sense to people?
yeah, I get what you're saying. Okay, so then for 4.3, what do we think in general? Like, do we think it's yes, no information?
I think it would be no information given Dr. Rabo's explanation of it.
Oh,
If
I'm
we
so
were
sorry.
currently assessing the outcome regarding the Doppler ultrasound examinations of the ductus and those, then obviously it is explicitly stated that the primary investigator was the one who was measuring that. However, since we are currently doing the Rob2 for the outcome of contractions and as a result, labor, I don't have definitive proof that the primary investigator who was unblinded was the person directly in charge of analyzing the contractions using the tachometer. Mr. David, do you see what I'm saying about that?
Yes, but there's also stated in the paper that the primary investigation was not only doing the scan, but he was also the one reviewing the the patient's records in order to look at the things that they were reported in these records, like secondary effects and other outcomes.
Yeah, so that was the outcome of maternal side effects. So they were reviewing the nursing notes. Is that what you are talking about currently?
Yes, but there was also, like, for example, the results from the tachometer would also be found in the patient's records.
Yes, that is very
So,
true. But is this asking about the person who actually did use the tachometer, or is this asking about the person who read the results of the tachometer? Because that could very well be two different people.
I mean, the one who recorded the information that was found in our study was the investigator that was invited because he was the one that went to see the clinical records and he took that information.
Yeah, I think I agree with Mr. David. It's because under the meta section, it explicitly stated the investigator was not blinded, so we can assume there was one investigator for the entire s- for the entire study. So that's why the investigator that was assessing the participants, he would have known if they received which intervention they received. So that's why I answered yes.
Okay, makes sense.
Okay, so do we all agree that it would be yes for 4.3?
Yes.
Or okay. For 4.4, since we answered yes to 4.3, we have to answer 4.4. So what did you guys answer for this one?
I said no.
Yeah, I said probably no. I think like since they carry basically the same weight, because it's like a objective measure. So like you're just either using the tachometer or like you're asking the patient. So there's like no way like really that you can like influence your judgment for it since it's like a number you get.
You could probably look at a pregnant patient and know if she's having a contraction or not.
Yeah, exactly. So do
Because
we
she will
all
not be looking happy. Having just gone through this weeks ago, I will tell you, everyone around me can tell when I was having a contraction, at least at this stage. Early contractions might not be so obvious, but I believe that it is pretty apparent and not open to interpretation at this stage if a woman is having a contraction or not.
Yeah. So that's why I answered probably no or like no, basically. So do we all agree that it would be like a no for this for 4.4?
Yes.
Okay, awesome. And then since we answered no for 4.4, we don't have to answer 4.5. So the overall risk of bias judgment was low based on the algorithm. Did everybody get that?
Yes.
Okay, okay, great. We can move on for domain 4. On domain 5 for 5.1, were the data that produced this result analyzed in accordance to a pre-specified.
And just to clarify that, because of the not blinding of the investigator, in this domain, we concluded that we have some concerns also. We
Okay,
did
yeah, I get that. I think the algorithm, because I use like the crib sheet or whatever. Like they provided a picture with like the algorithm. And if you followed the algorithm with like our answers, I think it produced a result of low. I'm not too sure. Let me check.
I know what you're saying, but like intuitively, you would think if the outcome assessors, the principal investigator was not biased, there would have to be some concerns about that. Like just
Yeah,
without using an algorithm. But that would be weird if the algorithm does say that even though the principal investigator was not blinded, it's still low. So
yeah, the
let's follow through it and see what it says. And if it does say that, I
okay,
think that
so
I think it's wrong.
I have the algorithm up on my screen. Can everyone see it?
Yeah.
Yeah.
Okay, so for 4.1, we answered, I think we answered no, right? For it, we concluded that it would probably be an appropriate measure. And then for 4.2, we said we also did like no, probably no answer. And then for 4.3, we said yes, the outcome assessor was aware of the intervention. So then we would go to 4.4, and then we said, could the assessment been influenced by knowledge different intervention? We concluded that it would be a no, a no for it. So then it would go to low risk based on
I
the algorithm.
see. So even though it's not ideal that the outcome assessor was aware, because the outcome assessor knowing couldn't have influenced the intervention, then it goes back up to being low risk. Okay. I understand now why both things can exist at the same time. Why it could have a outcome assessor that is not blinded and still be low risk. And the differentiating factor there is the fact that the assessment couldn't have been influenced, even if they did know. Does everybody understand?
Yes.
Now we're sure that this algorithm that we're using is correct, right? It's not from like Chat GPT, or it's not like some weird, like random, like this is the official algorithm that we're supposed to use to be official, right?
Yes, I pulled this straight from the crib sheet, and I think it's also
Perfect.
this one too. I'm pretty sure under since they included. Yeah, they have like
Ah,
similar
very
lines.
nice.
So
Okay, so
that's where I
Mr. David, do you understand how, even though the principal investigator was not blinded, it could still be low risk because of the fact the principal investigator, like, it couldn't have been influenced whether the principal investigator knew or not.
Yes, I understand.
I'm sorry, can you repeat that?
Yes, I understand.
Okay. So Gloria, you want to circle the main thing that I'm talking about on, like, the main differentiating factor here? It's
I don't know if I can.
4.4. No, just put your mouse
Oh
over it.
yeah, like
Circle.
right.
Yes, yes. Everybody see 4.4. Could assessment have been influenced by knowledge of intervention? And because we said no, that actually brings it back up to being low risk.
Yes.
Well, now you're just dancing your mouse all over the paper. Okay. Sorry to interrupt. Gloria, any parting words before the next person in alphabetical order, who is Critica, is gonna go?
Not really. Okay, I'll
Okay.
stop my sharing.
Okay, can everyone see my screen?
Yes, we can.
Yes.
We left off on domain 5, correct?
Yeah.
All right. So what did we put for 5.1?
I said NI because the protocol was not available.
Okay,
I
does
also
and
said NI.
yeah, I agree. They didn't confirm. No, the report confirms the protocol exists and was formally approved, but once again, it wasn't explicitly stated. So we can move on to 5.2 if all of us agree on NI. Yes?
Yes.
Yes.
Okay. So what did everyone put
Yeah.
for 5.2?
I put NI because the study does not provide sufficient information about pre-specified measurement intentions or indicate that like one time point was selected based on the results, because I guess we'd need like a trial protocol or like a pre-specified analysis plan to confirm that.
Yes, I agree. Does everyone else agree?
I said probably no because they reported contraction frequency for both 2 and 4 hours, like at both 2 and 4 hours. But again, it could also be NI.
Did anyone else put probably no?
I put NI, but I also see what like Abigail is saying for like probably no. Because like for contraction measures, like it's like you count the contraction, so there's not really like scales or definitions or time points for contractions really.
I I agree with you, Abigail and Gloria, but I guess like the reason why we put NI is still like what Lydia said. So I'm not sure whether it would be like based on what Abigail and Gloria said or what Lydia and I said. Does anyone else, like Mr. David, have an input on this?
Hello. Well, on the first part of this domain, we we fulfill no information because in order to compare if the analysis were according to a pre-specified data and a pre-specified measurement, we will need to have access to the protocol. and compare the results that they reported and how they measured in the article and how they said they were going to measure in the protocol. So in this first stage, we do not have answered, we do not have the protocol to review and compare if the information in the protocol is fulfilled with the with the article, because we reviewed the article.
Okay, so yeah, I think since we don't have the protocol and it can't be verified, then it would just automatically make it no information. Is that correct? Um, Mr. David, is that like sort of consistent with your reasoning?
Yes, because the thing with comparing with the protocol is that if they say in the protocol that they were going to measure it in some way, like for example, they say in the protocol, oh, we're going to measure for the tachometer, for example. But when you go into the review and they measure it with a different technique or in a different way, it tells you that, and in the protocol, there's no justification, because when during research there are changes in the protocol, these are justified on why did the protocol change. So if there's no justification on why the measurements or the analysis put in the protocol that they were going to do, like for example in the protocol they say we're going to measure this, and you go into the article and you do not find that thing that they said they were going to measure, it raises some concerns about about the risk of bias, of why they are not reporting this, or why did they not measure the thing that they say they were going to do. So in order to evaluate if it's according to the pre-specified, we're like evaluating if they follow the protocol that they had before.
Okay, I understand. Thank you so much for clarifying. So I think it would be no information based on that clarification. Does everyone agree?
Yeah.
Okay. We can move on to 5.3. Does anyone want to say their answer for 5.3 as well?
I basically just had the same reasoning for 5.3 in that like there's no pre-specified intentions available, so it's hard to come to a conclusion. So I'd put NI.
Yeah, I second that. I put NI as well. So my overall risk of bias judgment was some concerns. Does everyone agree with that?
Yeah.
Yes.
We can move on to domain 6. Or no, there's no domain 6. I apologize. So my overall risk of bias judgment, I think it would be some concerns. I think that was the highest risk of bias that we got.
Yeah, I agree with some concern for the overall.
Okay. Um, are we moving on to the next outcome, or are we only doing?
Well, did Mr. David say that his final assessment is some concerns?
Yes, our final assessment is some concerns for this.
All right. Okay. Very good. So pretty much we all got the same thing for the first outcome. Now, my question is, was the first outcome just effectiveness of tocolysis, or was the first outcome specifically contraction frequency 2 hours? Because I don't think that we're required to really break it down into 30 different outcomes. I think just tocolysis success in general could just be one outcome. It doesn't need to be Well, what do you guys think? Did you do for those of you who got 20 or more outcomes, did you break down the tocolysis or tocolysis, whatever, tocolysis into multiple outcomes, or was that just one? How did some of you get so many outcomes?
I did it based on like if they had like a numerical result. So like for like the that one table they gave, like I did all the I assessed the RB2 for all of the outcomes since they gave like numerical specific numerical results for each of them.
Now that is thoroughly complete, but I felt like I read somewhere in the directions that you don't need to do it to that extent, because then we would be having 300 pages. Somebody's mic, Abigail, since you're the host, whoever's mic is going off, can you mute them?
Yep, all good.
So basically, now correct me if I'm wrong, but if we wanted to have like the world's longest ROB2, we could divide all outcomes into that, but we are allowed to have like one outcome be the tocolysis in general, and it includes the contraction frequency at 2 hours and that sort of thing. You know what I mean? Like that whole table 2 could just be one outcome. And I believe we would be allowed to do it that way for simplicity's sake, because it's a lot of work for each record to be 300 pages of ROB2. Mr. David, your outcome of tocolysis was only just tocolysis in general, which encompassed all the data in table 2, correct? You didn't do a risk of bias assessment for each individual feature of tocolysis. Is that true?
Yes, that is actually true.
Okay. So, can all of you in this room state if you did the outcome for tocolysis, did you do it to encompass all the features of tocolysis, or did you do a risk of bias for each individual feature of tocolysis?
I did it for each outcome, like each.
And who is I? Sorry, I'm not. Is that Abigail?
Yes.
Okay. Well, that's because you're very complete, and if that's how you do it, then please continue. Wow, that's very detailed, and that's probably why yours is several hundred pages long.
Yeah.
I'm not saying that that's wrong. I'm just saying that if you did have tocolysis and all of the features such as contraction frequency at 2 hours and that sort of thing, if you did it individually, I don't think that's wrong either. Do we agree that either way, one way is very, very complete and would result in hundreds of pages, and one way is complete enough? Do we agree with that?
I think both of them would be okay to do, like either or.
All right. So what I think we should do next is pick another outcome and look at everybody's submission and determine who should be given authority to do risk of bias I mean, this one does meet Prisma because we all did it independently, except for me. I actually didn't do this outcome. I must have slipped my mind. But enough of you did it independently and then came together, which is enough to meet Prisma requirements. Do we agree on that?
Yeah.
Yes.
Okay. So this could be checked off as being having been completed for real. But we need to clear some of you in going and doing these on your own. So Abigail, obviously you're cleared. Gloria, you've been doing these, right?
Yes, I've been doing them with Critica.
And Critica, Gloria, Abigail, you guys have my full faith in your ability to do this. Lydia, have you been cleared to do these on your own?
No, not yet.
Do you feel, and apologies because I was having a hard time based on your voices who was talking, but do you feel like you are confident enough and to do these to start doing some other records yourself?
Yeah, I think so.
Okay. Now, for those who are not here, particularly Ahmad, let's get his out and analyze it. We'll pick a outcome. His looks really good to me, and I want us all to look at it and see if we can approve him for working on his own. So if we get Ahmad's out, you can see that he actually at the top labeled and explained. I cannot believe he is in high school. Just such impressive work. I mean, at the level of a college graduate, and I've taught thousands of students, so I think that he could very well be ready. So if you guys want to get his up, you can see that he really broke it down into a lot of outcomes. Meanwhile, me over here, I only broke it down into 13 measly outcomes. He did a more complete job than I did. So if we just take, well, let's see what his first outcome was the systolic ductal. So yeah, this is another example, and whoever's taking notes, and I feel like we need to make a note of this timestamp because this is going to be a really important thing. Whoever is screen sharing, can you get like just a blank Word document up and make like a big note to like pay attention to this part? Because this is one of these pieces that is kind of hard to grasp. So just like, I don't know, make it really big so that if we go through, anybody watching this on YouTube knows to stop it at this time marker. Just get like a blank document up and put a bunch of exclamation marks. Whose screen am I looking at? Whoever's screen is up, get a big old blank document, make it come up, and do a bunch of exclamation marks because this is going to be important. Yep. File, new, big old thing, lots of exclamation marks. Yeah. I don't know. I guess we're about how many? It's 11:26, so I guess an hour and yeah, there we go. Okay, 11:26. So the point I'm about to make, for me, I use the outcome of just like an overarching, more generalized outcome of increased DA flow, like increased velocity, which in turn means constriction, which in turn means closure of the ductus arteriosus as just one outcome. Ahmad, on the other hand, actually went through each and every feature of that. For example, systolic ductal arteriosus velocity and diastolic. And then he did one at 0, one at 4, one at 24. You see what I mean? So if you take a look at Ahmad's outcomes, 7, 8, 9, 10, 11, 12, 13, 14, 15, those are all different outcomes related to increased flow, which is an indicator of closure of the DA. So he did the ROB2 for 1, 2, 3, 4, 5, 6, 7, 8, I guess about 8 features of it, which is admirable and very complete and not incorrect. But I, on the other hand, just did like one ROB2 based on those features in their entirety. Does everybody understand what I'm saying? It's comparable to how we were just discussing the outcome of tocolysis, which can subsequently be divided into contractions at 2 hours and contractions at 4 hours. And yes, you can do an ROB2 for each aspect of that. You could do an ROB2 for the contractions at 2 hours, the contractions at 4 hours. But my understanding, and I think that Mr. David agrees with me, is that it is sufficient to simply do the ROB2 based on the overarching item or result, aka outcome, which would be tocolysis, and then in the Ahmad example, the overarching result, aka outcome, which would be increased velocity flow through the DA, which means closure of the DA. So does that? I feel like that was a very long explanation to say that he did 8 ROB2s for one outcome, which is insanely complete, like so complete and like perfect. Whereas I, on the other hand, just kind of did one for all 8, which my understanding is that neither way is incorrect. Could we all, please, if you think that I was not complete enough, please let me know.
I think it would work. I think basically like he did it individually, but like for those individual measures, like a lot of them would have repeated like same answers, if you know what I'm saying. Like so if you combine them, you'll still get the same answers if you did them individually. So I think either way it would work since like they would be
Right.
measured the same way and like unless they had like
I
missing
think,
data for each measurement, then it
right,
would be
right.
different.
I think, yeah, it's a lot of the same stuff. But I like the way Ahmad did it, and if he keeps doing it that way, I love it. That's great. So let's take a look at what he did and decide if we should all approve him to do this on his own. All right, so first he numbered his outcomes, which are very broken down into many, many outcomes, more than twice the outcomes that I noted. And then, so the first one that he did was Solendac versus indomethacin, which is the comparator, indomethacin. And then the first outcome that he listed here was the systolic ductal arteriosus velocity at 0 hours. And then he referenced figure 2.
I have a question.
Sure. Who is I? Sorry, I can't. It's not telling me who's talking, so I don't really know who said that.
Abigail.
All right, go ahead.
So at 0 hours, would that be before they started treatment?
Wouldn't that be like as soon as they started treatment? I don't know. That's a great question. I would assume it's like the second they started treatment, but does this study actually say 0 hours is before they did it or at, heck, it could be as they were doing it.
It does
Maybe the
say.
patient. Okay, what does it say?
It says like 0 hours was pre-treatment. Like they referenced like pre-treatment 4 hours, 24, 48. So pre-treatment is 0 hours.
Oh, interesting. So all of this basically is not an outcome, but it's a baseline. But
Yeah.
that's not like a bad thing. We'll just skip it, right? It's like extra work,
Yeah.
but it does show us that Ahmad is willing and able to put in the time that is required to do these. So that's one thing it certainly shows us. That's a great point, is that if it's baseline, we don't need to do it. All right. So actually, let's pick one. Let's go to his next one, which is on page 11 of his document, which is 271 pages long, mind you. That one's going to be the systolic ductal arteriosus velocities at 4 hours. Okay, so now we know at least there's some medication on board in this one, because the first one would have been baseline, so we didn't need to do that. But it certainly did prove that Ahmad is very dedicated to this. Okay, All right, so if we go figure 2, sure, yeah. Intention to treat, yes. Journal articles, yes. Okay, so Lydia, I believe that you were going. So if you just go through 1.1 and see if we agree with Ahmad's answers, and then we will go through each domain he did, and at the end we'll decide if we think that his work is worthy enough of approval of branching out onto his own.
Okay, and to clarify, which outcome are we doing right now?
So on his page 13, we're going to do the outcome of systolic ductal arteriosus velocities at 4 hours.
Okay.
Go ahead and read domain 1.1, and then we'll see if we like his answer.
Was the allocation sequence random? Sorry, just to clarify, so I'm just going through Ahmed's and not my own document?
Yeah, because what we're doing now is we need to start approving other people to branch out on their own, because those of you who are already doing these on your own certainly would benefit from additional help.
Okay.
And I believe Ahmad is ready. And everyone who is currently on this call has already been approved, yes?
Yeah.
Okay.
Okay, so for signaling question 1.1, he had put NI. Do you guys agree with that response option in the reasoning?
Yes, that's what we also concluded together.
Okay.
And this wouldn't be any different from the one we just did with the tocolysis as the outcome, correct? I mean,
Yeah, I
Yeah.
believe
To be
these
similar.
are all going to be the same.
Yeah.
Yeah.
All right, please continue.
Okay. Signaling question 1.2, do we agree with his answer and reasoning?
Yes, I think that's also what we concluded after we went through it together.
Yeah, NI. And 1.3, I believe we also had the same answer, N, or
Yes.
probably no. Okay.
Nice.
And
He's doing pretty good so far.
okay. Domain 2, so 2.1, he had put probably yes. I believe we decided on NI for this question. Is that correct?
Yes, that is correct.
Oh,
Let's read his reasoning and see if we like it. Out loud.
oh, okay, I can read it.
Because remember, the people who aren't here are going to be watching this video. So, like, you want to read it out loud.
Okay. This is because the medication is said to be taken individually in this paper, right? And like the thing is, if the envelope is telling them if they are in indomethacin or Cilindac group, then they should know what group they are in then. The quote, randomized by sealed envelopes to receive either indomethacin or Cilindac is suspicious because it suggests the envelopes will reveal what group they are in.
Oh, that's interesting.
Do you guys agree with this comment?
I think a little bit, but for like the randomized by sealed envelopes, I think he's reaching a little bit because I don't think it says whether or not like the participants did they receive the envelopes? I don't think it explicitly says, right?
Yeah, I think, well, that's a good point. I would assume, but again, that's what gets us in trouble is assuming. But let's just say the participants received it. When they opened it, does it say endomethacin, or does it say group 1, or does it say group A? My
I guess we
understanding is
wouldn't
it
know.
doesn't say. We don't know. We just
So
don't know.
yeah, or like if the envelopes were for the like carers, then the carers would know, but not the participants. But it doesn't give any information on like blinding for the participants either. So
Right. So we don't know that the participants even got the envelopes. Maybe the carers got the envelopes.
yeah.
That is why I had put NI, and I believe we decided on NI before.
Yes.
Okay, so if we did approve Ahmad to do this on his own, whenever it comes time to pair up with his partner, which I guess will be Lydia, right? Because Lydia, we're approving you today and you don't have a partner, right?
Yeah.
Well, when Lydia and Ahmad come together to go over their independently completed ROB2s, that's when this discussion would arise, yes?
Yeah.
Yeah.
And everything would still be Prisma compliant. All right, well, let's continue and see his reasoning. He clearly has critical thinking skills, so that's good. Let's continue.
Okay. For signaling question 2.2, he put probably yes. I can read his reasoning. This is because in the paper they had many co-interventions they could adjust, but I will talk about one specific one, magnesium sulfate. Now, the paper specifically said magnesium sulfate was weaned if the contraction frequency decreased. Now, although this quote is just checking for the contraction frequency to administer magnesium sulfate, doesn't the person administering it have to know about the intervention they are taking? Magnesium can't just be given due to contractions. They have to look at other things as well, including what intervention they are taking.
What do y'all think about that?
I think that magnesium, I don't know if I think that for this one, he's talking about magnesium sulfate, I don't think it really depends on the intervention that's given, because it's just based on the contraction decreasing. So I'm not sure. But
Think
again, the
That's
paper doesn't talk about if the people who delivered the magnesium sulfate knew about what intervention they were taking.
I
I
agree.
yeah, I
Oh, sorry, go
agree.
ahead.
I was
Mr.
just gonna say
David, do you have any items to note?
Hello. No,
Hi.
I agree because we have no information on if the participants or the caregivers that were delivering the interventions or the medicine were aware of the patient situation or the patients assigned groups. So we left it as no information.
Yeah, I agree. So I see what Ahmad is saying here is that maybe there are clues that they know, but actually, the administration of magnesium is done in response to the contractions. And so, let's just say you're a random nurse that has no idea that there's even a study going on, and then one of your patients is having contractions, you would go in and administer the magnesium sulfate. And so, that in fact doesn't have any bearing on whether or not they know what intervention is being given to the patient.
In that case, do we agree with NI as we decided before?
Yeah,
Yes.
Okay.
we
Yeah,
do.
his reasoning was good still.
Yes, and I'm sure that he will go back and watch this video.
Okay. Moving on to 2.3. Um, he had said no, and his reasoning was the paper does not list any deviations. They list the co-interventions as precautionary things that they could do if the contraction decreased or something else happened. What do we think about this answer? I believe we'd also put NI beforehand.
I don't remember what we put, but I think his reasoning was similar to what I said, because I originally I think I put probably no, and I also said they didn't list any deviation. So that's what I said originally, but I think we changed it later.
I think, from what I remember, yeah, we have the same reasoning, except we just picked NI as a response instead of N, or probably no.
Yeah.
Okay. What are we agreeing with for this signaling question?
NI.
NI.
Okay.
I think we agree with the reasoning, but not with his selection for response options.
Yeah.
Yeah.
And he will watch this and he will learn from it.
Okay. So 2.4, 2.5, we don't answer, and 2.6, he doesn't have an answer. He might have forgotten to answer this question. So should I just move on to risk of bias judgment?
Yes.
Okay. He had put low, and I believe we concluded with some concerns.
Okay.
Yeah. Maybe he's not following the algorithm. I'm not sure.
Oh, no, because I think even if he
His
did follow the algorithm, his answers were different enough that it would have.
Yeah.
Okay. Should we move on to domain 3?
Yeah.
Okay. Okay, for 3.1, he had said yes. His reasoning was yes, the paper does say they included data for everyone. This quote says no randomized patients were excluded from analysis, which proves that everyone was included.
Yeah, that's the
Okay.
answer.
And was this the ductal arteriosus velocity?
I think
At
those were
Out.
4 hours,
Okay.
one that starts on like page 11 or 12 or something.
Okay. For this one, I would agree, except I believe in the paper it said that there was like incompleted or there was an inability to obtain accurate ductal velocities on each subject at each time
Oh yeah, I
interval.
remember that.
So
Yes.
Oh, it says
I,
specifically like, it was like a percent. They gave a percent for like four. It was like
yeah,
59 or 56.
64, 56, 47, and 39 for like pre-medication, 4 hours, 24, and 48 hours. So for this, I had put no.
Right, that's what I put for this one as well.
Okay. In the other cases, I believe yes would be correct for the other outcomes.
I think for like the deep pocket and like the amniotic fluid index, they also said like they got decreasing measurements. Like they didn't measure everyone for that specific outcome. So it would, I think for those like two other ones, it would also be no.
I wasn't sure if it was if ductal velocities were like regarded in like the deepest pocket or not. I had just included that in my note for the
No, the ductal velocity doesn't have to do with the pocket one. Pocket
Yeah.
one has to do with fluid from the urine, and the other one has to do with the ductus arteriosus. Two different organs. One's the heart, one's the kidneys. So my understanding is that the data, and this is a question, not a declaration of truth. Okay, the data decreased because women stopped being in labor and therefore just went home. Is that, you know what I mean? Like, if they stopped being in labor and everything is fine, it says somewhere in the results that they were just discharged home, but they were kept for a certain amount of time. Is that why the data points, like we were just discussing, decreased towards the end? Is because the women weren't even having, like, it's just they were better and they were discharged? Is that why there was less analysis? Like, if they're all fine and good to go, why keep them in the hospital and keep analyzing things? I mean, yeah, you'd probably want to do it because it's the study, but do we have a reason that this information was decreasing further on?
They don't give a reason. It says, unfortunately, we were unable to obtain accurate ductal velocities on each subject at each time interval. So,
Oh, so if it's at each time interval, then my hypothesis that the later times they weren't able to get because the women just weren't in the hospital anymore is not correct. Because if each time interval had that lack of data, then just forget about what I said. So we don't know why this is the case, and we shouldn't sit here and try to guess. Is that correct?
Yeah.
Well, then forget that I sat here and tried to guess. Erase that from your memory.
Okay, so for this signaling question, what are we agreeing with? I had put no in my own document.
Yeah, I'd agree. I also put no for this one.
Me too.
Okay. Um, so then the other signaling questions would have to be answered, but he didn't put anything. So should I just move on to domain 4?
Mm-hmm.
Okay. Okay, for 4.1, he had said no, and his reasoning was the method of measuring the outcome was appropriate as ductal arteriosus velocities are measured through an ultrasound, which is what they did in this study. I agree. I actually put PN, or probably no.
I put that as well.
I put no.
Okay.
I
Um,
agree.
okay. 4.2, he had said
Mr.
no.
David, do you agree?
Uh, you will have to excuse me. Here in the office, somebody else was talking to me in regard of a couple of things, so I couldn't pay attention to the last part. If you could repeat.
We're on signaling question. What was it? Lydia, you were leading, right?
Yes, it was 4.1.
4.1.
So we're doing signaling question 4.1 regarding the outcome of was it systolic velocity through the DA at time 4 hours?
I think so.
And we're looking at our researcher Ahmad's answer to determine if we think that his ability to do this is good enough to be granted approval to do it on his own. All right. Lydia, please continue where we left off.
Okay, so I think we moved on to 4.2. He had also put no, and his reasoning was no because the paper only describes one method for measuring ductus arteriosus velocities, although it does not explicitly state that these velocities were measured using ultrasound. The authors discuss using ultrasound and then list ductus arteriosus velocities among the measured outcomes. This suggests that the velocities are likely assessed using the same ultrasound method. I would agree, and I put probably no.
Sí, así. Americano, expreso, un expreso.
That is also what I put for 4.2.
Okay. Are we all agreeing with this answer?
I don't have any reason to believe that the endomethacin group would have their velocities measured, like, I don't know, on someone's iPhone, and then the Solinda group had their velocities measured on ultrasound. I would say that it is not different between the intervention groups.
I agree.
Me too.
Fabulous.
Okay. Moving on to 4.3, he had said yes, and he said the paper explicitly states that the investigator was not blinded to group assignment, and this quote was from the paragraph where they were talking about the ultrasound examination, which is done for the outcome assessment. I agree, and I also put yes.
I agree as well.
Me too.
Okay. 4.4, he put probably yes, because as since an ultrasound is being performed, that exam requires some level of judgment from the assessor. So if the assessor knows who is in what group, that could potentially hinder the true results since the results come from their own judgment. What did I put? I had also put probably yes, and for similar reasoning.
Wait a minute. How are the results coming from their own judgment?
I think it's because
they
they're
have to-
looking at the ultrasound and then they're like determining, like using their own judgment, like they have to make an assessment based on what they know.
But it says that the volume, it's numbers, right? You can't. Somebody correct me if I'm wrong, but judging velocity is not really up to your opinion. It's not
Actually,
like they're sitting here like that looks fast or that looks slow. Wouldn't velocity be a number?
Maybe like if the value was let's say like at a cutoff, they might use their judgment depending on what treatment group the participant was in.
I guess they could do that. That would be messed up of them, but yeah.
Yeah.
Wait, let's see. Manual on-screen calculations of peak velocity, systolic and diastolic, were performed using vascular examination pack. Well, what is the vascular examination package? At least 5 acceptable waveform measurements were required for a successful study, and the mean of these values were recorded. All measurements were performed during fetal apnea. So if we're talking about a mean of values, so I'm at the top of page 224, the second paragraph on the top right. Yes, correct. I am of the understanding that to assess a velocity, there is a number somewhere.
I think I agree.
It's usually like what, meters per second squared or something like that, right?
yeah, I think they give it in a graph. Like they have a graph with numbers comparing everything. I think it's on page 4.
Mm, Uh,
Yeah, they give a graph with like velocities.
oh, they do. It's centimeters per second. I don't know, guys. I don't think centimeters per second is open to interpretation or.
I think maybe he was thinking about like maybe he thought it was about like looking at the heart itself. Because I think that's what they did for the actual like if they diagnose the PDA actually.
So it would be, let's talk about two circumstances. You are a coach and you're watching someone in front of you run, and you say, that kid's running fast. That is certainly up to interpretation and it is subjective. And you could say that kid's fast because he's your nephew, and so that would be biased. But if you're a coach and you have a stopwatch and you say this kid is running at however 7 meters per second squared or what have you, that's not open into interpretation, right? That's pretty objective.
Yes, I agree.
I also agree.
So let's get back to what Ahmad said.
Okay, so he had said probably yes. But with the clarification that you provided, I would say probably no, since it's like quantitative, out like numbers, and it's not like based
Yeah.
on judgment.
Right. And they even give us the numbers.
Okay, so are we agreeing with probably no or probably yes or what other
I think probably no would be the best answer. Or
Right.
no. I think both have like the same weight, so
yeah.
Yeah. Agree.
Okay. Moving on to 4.5. He had said no information, and he said, we don't know. We only know that the person who knew was in what group, and even though it probably could have happened, we don't know in this study. What did I put for this? I put probably no for this one. What did you guys put?
I think since we answered um probably no for 4.4, we wouldn't have to do 4.5.
Oh, yeah, you're right. Okay. So what would the risk of bias judgment for this domain be?
Do you want to
Um,
bring up the little algorithm map and
yeah,
follow along and see?
I
yeah.
believe it's low since we got probably no for 4.4.
And don't forget to follow the map, because even though it might seem like obviously like, oh, this looks terrible, it's high, don't forget to follow the algorithm map just to make sure.
Okay, so for 4.1 and 4.2, I believe we had probably no. Okay, let me pull up my graph. Okay, so probably no, and then it was yes. And then did we agree with probably yes after that?
I think we said probably no
Oh.
since it was given it as a number.
Oh,
Yeah.
right. Probably no. Okay. And then we had said probably no or no.
For 4.5, it'll be NA.
Oh, NA. Sorry. I'm so sorry. Okay, so probably no, yes, and then probably no.
Mm-hmm.
Okay, probably no. So that would be low risk.
Yeah.
Mm-hmm. Yes.
Okay. Moving on to domain 5. For 5.1, he said NI, and he said we don't know as we only looked at the paper and no other external documents. I think we all agree with this.
Yeah.
Okay. 5.2, he said probably no because the paper does not, or the paper does highlight that they use ultrasound and they list the ductus arteriosus velocity being measured after mentioning this exam skill, so probably no. They use this assessment method only. I think we concluded with NI because we don't have any, we can't confirm without the trial protocol or SAP.
I think we did say it was NI since yeah, I think we did put NI for both of
Oh, we
them.
did. Mm-hmm.
Yeah, and 5.3 for the same reasoning. Okay, so that would be some concerns, which he got. Okay, then overall risk of bias judgment, I believe, would be some concerns.
Yeah.
Okay, I think he did a pretty good job. What do you think, Dr. Weigel?
I think that it is very clear that he has the critical thinking skills and motivation to do this. I think that maybe before clearing him, we'll require him to watch this video and maybe type out like his understanding of the clarifications that we made after having watched this video, and then we can approve him. Now I know that everybody's got places to be, but the more people that we approve to take on Rob2s independently, the faster we can get a move on in this part of our research. So I think our final opinion for Ahmad will be he needs to watch this video and then provide me with his comments on this video. And then I'll decide if at that point he's clear. But I think that he shows really like high level of intelligence and critical thinking skills and seems to understand the directions behind completing the Rob 2. Uh, but I would like to get a few more people clear today, because the faster we get people working on this, the the better shape we're going to be, instead of people just sitting around for the next week not knowing what their next step is. And my next vote for clearing somebody is going to be Jordan, who unfortunately had to leave but was here. And I think the best example, so we should get hers out and look for, since we just freshly did the outcome regarding the ductus arteriosus and velocities uh, of movement through, and again, increased velocity equals more closure. So if you can find her outcome regarding velocities or closures, whether or not she divided them into 8 subsequent outcomes to explore through Rob2 as Ahmad did, or just one like I did. And again, maybe I'm just not being as complete. Let's try to find what she did. So Everybody get Jordan's out and we can see if we will approve her for. She has not already been independently doing these, so it would be beneficial to all of us if she did meet our approval for authorization to do these on her own. All right, so I'm controlling F for velocity or ductus or that. So peak velocity.
I think she only did the outcomes from table 4.
So she globbed all ductus arteriosus outcomes together in a similar fashion as to I, right?
I'm not seeing that at all. Just the outcomes from table 4.
Yeah, she doesn't have anything on the ductile velocities, I believe.
Well, outcomes from table 4. Oh, so she didn't get into like things regarding figure 2 or I wish you guys could see. I know it's killing a rainforest, but I print mine out and I color coded the whole paper, like crayons, colored pencils, and for anything related to flow or ductus arteriosus, I appropriately colored red. So she doesn't have any outcome. First of all, does she nicely list out all the outcomes the way Ahmad did? Because I love that he did that. That was very clear.
She did not.
Okay, so let me just scroll through. So the first outcome she assessed was birth weight. So wait, did she only assess outcomes that were listed in table 4 and skip the whole ductus arteriosus and fluids and amniotic fluid pocket and all that?
Yes.
She does have 65 pages. All right. Well, I think that was a big miss there. So we'll have her watch the end of this video. Let's see. Who else could we? Does anybody have any good vibes about anybody else? Should we try Shanika's? Did you guys? I know that there is this file with everybody's submission. Did you guys look over other people's submissions? Okay, so Shanika's, I don't think. I
She
mean,
only did it for one outcome, I believe.
yeah, so we won't look at that. Let's try Laksha. So she said that she's not here because this was the exact time frame that she was permitted to move. So she at least, had a valid excuse that she told me about ahead of time. So she has a legitimate reason for not being here. So she only has 12 pages, which would make me think that, but she has multiple tabs. There's something. So actually, let me go back to Jordan's and just make sure that she doesn't have multiple tabs. No, Jordan does not have multiple tabs. So Laksha does have multiple. Oh, interesting. So Laksha has multiple tabs. So she did outcomes of tocolysis. She did an outcome of the urine related ones. She did an outcome of the ductus arteriosus ones, and she did an outcome of neonatal outcomes, which actually, albeit not very many, is probably the minimum sufficient to still be good enough. Obviously, assessing for 26 outcomes is a lot and great and wonderful and probably perfect, but I think 1, 2, 3, 4 outcomes, as long as they encompass the little mini underlying outcomes, is probably actually sufficient. Now, I am making this judgment based on a random sentence that I vaguely remember reading in the 75-page document that explains how to do this, that you are allowed to, at your discretion, lump the outcomes together. Again, like the tocolysis with the hours, 2-hour contractions at 2 hours, contractions at 4 hours, or lumping the different velocities together and with the ductus arteriosus category. And correct me if I'm wrong, if you adamantly believe that every single data point needs to have its own ROV2, and if you are adamant that that's the way to do it, like, please speak up, because I don't want to, not give it a good go. But My opinion is that the way Laksha did it is, albeit not very complete or as detailed as it could have been, is enough to meet the minimum for a successful ROB2 for this record. Do we agree?
Yes.
All right, so let's go to her fetal ductus arteriosus outcome data, of which she's just kind of doing all the velocities at all the times together in one ROB2. All right, so we'll see if she did it and we like it and we can approve her, which would be great because, again, the more people that we approve, the more progress we can make. Let's go back. Abigail, would you like to read domain 1.1 on Laksha's document under the tab that is labeled fetal ductus arteriosus?
Sure. For 1.1, the article states participants were randomized by means of sealed envelopes. The method of generating the random sequence is not specified, and then she went with PY for this one. Do we agree with 1.1?
For 1.1, I think we answered NI, I'm pretty sure for this, for 1.1 and 1.2.
Yeah. So for 1.2, she said the use of sealed envelopes is a method of allocation concealment. And then she also said PY for this one as well.
Well, it's concealment, but is it random?
It doesn't specify that. So I think the best response would be NI for both 1.1 and 1.2.
All right. Continue.
For 1.3, baseline characteristics were similar with no statistically significant differences reported. And then she said PN for the response. And I believe we had no for 1.3.
Yeah.
Which is similar to PN, so it doesn't really change anything.
Okay.
Our judgment was some concerns for domain 1, but she said low.
Okay, interesting. Well, read, let's see what she put in the box.
Same as assessment 1 for tocolysis, adequate randomization and concealment, baseline characteristics balanced.
Well, do we agree the baseline characteristics are balanced, but do we know anything about the randomization?
No, we do
And
not.
well, we know it was concealed, but again, it was concealed, but was the envelope clear? Could have been just a clear envelope. Okay, so we did not get the same risk of bias judgment for domain 1 as Laksha, but we'll continue moving on and see what she did for domain 2.
For 2.1, she said the trial is not described as double-blind. Participants would likely be aware of their medication due to different dosing schedules. And then
Which is something we had talked about, but does that necessarily mean that the patient would know? I think Mr. David brought up before that even if they had different dosing schedules, what if every 2 hours they were given a pill that was blue and it didn't say what it was, and it doesn't say one way or the other. And also, this is the 90s. You couldn't just get on the computer and say, if I'm being given this med every 4 hours, does it mean that it's this med? I bet people wouldn't know. Plus, they're in the hospital. But you can't just make assumptions like this either.
Just to make it clear, when a study is blinded, the investigators take measures to assure that, if, for example, one of the medicines is injection and the other one is oral, they will often do like, we will give a placebo that is injection and a placebo that is oral to the other group in order that they do not know in which group they are. So they always take measures to conceal to the patients in which group they are. In this case, they are not described if they are blinded, and therefore they do not describe if how they hid, how they hide, sorry, the or how they conceal to every patient if they were in one of the groups. So we do not have information if it's blinded, and we do not have information on how they kept their patients and caregivers blinded.
Right. So, in and of itself, being given a medication at a different schedule doesn't mean that the patients know, because there are other things that can be done to conceal it. For example, if one medication is given every 2 hours and the other medication is given every 4 hours, the medication that's given every 4 hours may be given along with placebo every 2 hours, so that they're taking something every 2 hours. I hope that wasn't confusing. The point is that they could it could be concealed anyway, but ultimately it doesn't say what they did, so we don't have the information on it.
Yes, that makes complete sense. For 2.2, she said, given the lack of blinding and different dosing regimens, clinicians and nurses were likely aware of group assignment, and then her response was PY. But for the same reasons, we answered NI for 2.1, 2.2 would also be NI.
Okay.
2.3, the text describes deviations, including continuing in labor, delivery, or side effects, necessitating discontinuation. And then her response was yes for 2.3. And I believe we said NI for this one as well.
Yes.
Okay. If we said NI for 2.4, we don't have to answer for 2.3, we don't have to answer 2.4 and 2.5. 2.6, she said an analysis appears to include all available data from participants who remained undelivered. However, because missingness is related to the outcome, the analysis may not fully represent the ITT effect. And then she said PY. I believe we answered yes for 2.6, correct?
Yeah. That was for if since we're on the fetal ductal one, that was like they had like missing data, I think, right?
But that would be domain 3. This is asking if they did ITT or like per protocol analysis. In this case, I believe they did ITT.
Okay, wait, yeah, you're right. I got a little confused.
Okay, so for 2.6, are we going with yes or PY?
Yes.
Okay, so we're going to skip 2.7, and then the judgment in this case, she had some concerns.
Wait, can I jump in a second? Remember that thing that I was pointing out before, the different, like, what's the word? Like a whole different type of analysis that you do in the case where data is missing, or how they, man, how do I explain this? That there's like a way that they can see if the missing data would affect something one way or another.
Is it imputation or?
Yeah. One of those. And that would be on 226, where they said when the patient with advanced preterm labor were removed. Oh, okay. So basically, they did some kind of analysis to see how the outcomes would be different if the people who were removed were put back in. But I'm not sure if that's pertinent to this one. Do you guys remember there were different ways, different processes to see if your results are different, whether or not the people that are missing are there or not?
Yes, and I think that's for domain 3.
Okay, sorry, I was jumping ahead here. Okay, ignore me. Please continue.
Okay. For the judgment, Laksha said some concerns. Was that what we had?
Yeah, I believe so.
Okay. (3.1) The text states we completed acceptable ductal Doppler flow studies in only 64, 56, 47, and 39% of the undelivered parturients at pre-medication and 4, 24, and 48 hours respectively. This means only 64 at baseline and only 31% at 48 hours. Data were not available for nearly all participants. And then her response was no for 3.1. And I believe we had the same thing as well for this one.
Yes, we did.
3.2, the study does not provide evidence that missingness was unrelated to the outcome. Patients who delivered the treatment failure could not have ductal measurements taken. And then her response was PN.
Oh, you know what? This is when I was just making an assumption based on the missing data. I thought that it was because the women went home. Could be because they actually delivered their babies. The treatment failure would be delivering babies because the whole point of the treatment was to keep the women pregnant longer. Sorry, that was just a side note. Please continue.
Okay, for 3.2, did we answer PN or no?
I put no for this one.
Yeah,
Me too.
I think I did the same as well.
Yeah.
3.3, missingness clearly depends on the true value of the outcome because patients who delivered could not have their ductal velocities measured. And then she answered yes for 3.3.
I agree. I put yes as well.
Okay.
And this has to do with the 226 right-hand side, the 1, 2, 3, fourth paragraph in the discussion. Because the women who had the advanced preterm labor, like they were dilated 5 centimeters or greater, meaning that the baby's probably imminently coming. They were removed, but then they did that thing that I was talking about earlier where they tested either way to see if their removal affected the outcomes. And that's 1, 2, 3, fourth paragraph in the discussion. And then they were talking about how their study is different than other studies like that because they actually did include women who were super dilated and about ready to give birth. And the fact that they included women that were super dilated and about ready to give birth is probably one of the causes for the missing data, and that if the women gave birth, then you can't measure more because the baby's already out.
Yeah, so for 3.3, we're going to go with yes. 3.4, it is highly likely that missingness depended on the true value. Patients who failed tocolysis and delivered were excluded from further Doppler measurements. This is a classic example of outcome-dependent missingness. The missingness is also related to the intervention effect. If one drug is more effective, more patients in that group would deliver and be excluded. And then her response was yes for this one as well. Did we get a similar answer or was it different?
I put yes.
Okay. Which means the judgment would be high based on the answers.
Yes.
Did we all get that?
Yeah, it would be high.
Okay, for the judgment.
And since we always have to go with the highest one, the whole thing is going to be high.
Yes. Okay, for Domain 4, 4.1, Doppler ultrasound measurements of ductal arteriosus velocities is a standard and appropriate method. And her response was no. And I believe we all had the same answer.
Yeah, it was a no.
4.2, the ultrasound examiner was unblinded. Doppler measurements required significant technical skill, manual cursor placement, and subjective interpretation. Knowledge of the treatment group could easily influence measurements. And 4.2, her response was yes. And I believe we had the same response as well.
We answered, I think we answered like no for this one because like it was by like a number like centimeters over.
Actually, yes, we did say no for this one. Yes, 4.2 would be no, which means she was supposed to answer 4.3, 4.4, and 4.5, depending on her answers for 4.3.
Mm-hmm.
Okay, I'm gonna read her judgment. The ultrasound examiner was unblinded. Doppler measurements required technical skill, manual cursor placement, and subjective interpretation. Knowledge of the treatment group could easily influence measurements, especially given the expectation that endomethacin would cause constriction. This is a high risk for detection bias. And her response was high.
This is a hard one because while the distance from one point to another is not open to interpretation and that sort of thing, the determination of where to start measuring and where to stop measuring is open to interpretation.
Yeah.
I feel like it could go either way, to be honest.
Okay, would that mean 4.2 would be no, but then 4.3 could potentially be possibly yes?
Hmm.
No, 4.3 would be um
I feel like 4.2 could be yes or could be no.
Was there a description of different measurement protocol being applied to the two arms? Because if there was, then that would determine between a yes or no.
And I can't think of it off the top of my head.
On page 3 of the PDF for record 2905, on the right side, the second paragraph, it does say that the cursor was always less than 15 degrees and the sample volume between 1 to 3 mm.
It sounds like they were trying to be pretty, like, on point with it. That's the thing with these assessments is that there is no, like, exact right or wrong.
Yeah.
It depends on our critical thinking skills and our ability to understand what's going on here. Continue. Actually, Abigail probably deserves a little bit of break, so I think Gloria's next in the alphabet.
Okay, yeah. Do you want me to share my screen or should I just read off of Abigail's screen?
Or whatever's easier for everybody.
Okay, I guess we can continue reading off of Abigail's screen if you don't mind.
Sure
Okay,
thing.
I think okay, we're still on domain 4, so I see what like Laksha's saying about like how like the detection bias, but they gave like the number it was like a number and it wasn't like, oh, they didn't give it like it was fast or it was slow. And I think we all agreed that it was like for 4.2, it would have been like no, since it was given as a objective number.
Yeah, I agree. And also, it says that all scans were performed by the primary investigator using a Ultramark 4 ultrasound unit. So I think that's the measurement device for this. Not sure
Yeah,
though.
and it's like the same tool, so it probably wouldn't have, it's not like they use different tools for to measure it. So I think for 4.2, I would go with probably no. I think we agreed on probably no originally, right? Or like no.
Yeah.
Yes, we did.
Okay, and then for 4.3, it would be yes, since they were aware. And then I think for 4.4, I don't remember what we answered. We answered like, did we answer no for this one? Because we talked about like it was because they gave it as a number.
Yes, we said probably no for 4.4.
Okay, so Laksha got different answers from us for domain 4. But I think I understand her reasoning, so like her reasoning's very clear. But I think overall, like I guess she didn't like know maybe like the number like it was given in number form. So she might have misinterpreted it.
Did she get the same like overall risk of bias judgment for the domain?
No, she put high, and I think for us we got low because 4.4 was probably no or no.
Yeah, okay.
So there was kind of a big difference with that. Okay, so for domain 5, 5.1, she got NI, which is also what we got since um there was no pre-specified protocol or like the SAP given to us. So in that regards, we got the same. For 5.2, multiple time, um, I can't remember what we answered for this one though.
I think we answered NI for all of domain 5. I'm pretty
Okay,
sure.
yeah. I think that's what we did. Um, so she got probably yes for both of them. Um, so I think. Well, she said it's because multiple time points were measured, two measurements were taken, and then definition give. But they didn't give us like an actual like plan, so we wouldn't be able to determine anything. So that's why we answered NI. And then for 5.3, it was the same thing. Like we couldn't do it. Like an actual we couldn't get an actual answer since there wasn't a plan given, right?
Yeah.
Okay, so she got different answers from that. Um, and she ended up with some concerns, which is what we got. But I think if she answered probably yes to 5.2 and 5.3, it would have been I think it would have been high risk instead based on the algorithm. Since in order to get some concerns, you have to get an I or in both of them.
Yeah,
So
it should have been a high risk if she got those answers, I'm pretty sure. But
Yes,
okay.
that's a big point that we need to make, is that the
And we
highest
have
thing you go with has got to be the end.
yeah, and we have to follow the
Can
algorithm.
does somebody want to put those points in the classroom stream right now for the whole class to take note of? Yes, Dr. Waggle, I will do it right now.
I can,
Anyone?
sorry, I can
Excellent.
put
Go
those in the
ahead.
stream.
Nice. Very good. All right, so what are we thinking?
I think her reasoning is pretty good, but we did get like kind of very different answers for some of the domains. So I guess a part of it's because like maybe we didn't decide on the outcomes as a group before, so that could have contributed to it, but I think like I think people just need to do more practice for it.
All right, so here's what I'm thinking. In terms of who's been approved and who isn't, those who are approved are Abigail, Bipop, Gloria, Critica, Lydia. Did I miss anybody?
No.
All right. The next potentials for approval are Ahmad, Jordan, and Laksha. They need to watch this video and write some feedback and do an analysis of like what things they did differently than what we did, and maybe study that document more, that 75-page document with the that starts 20190822. What a great title for a document. And then next up, I think Avni is somewhere in the middle there, but I can't really tell because her issue is that she didn't justify very many of her decisions because I don't see very many comments in the comment box. And then last, Samiha and Shanika, they only submitted like a couple pages and only did one outcome, so I have absolutely no way to determine what their skill level is. Did I miss anybody?
I think that's everyone.
All right, so I'm gonna type out what I just said. Everybody here is approved, so please continue doing your Rob2s. We do have a bunch of applicants, and instead of accepting, like typically people with the great CVs and wonderful cover letters and all that, I am choosing people that seem to have experience and then giving them that guide that we created and asking them to submit a sample for my review. And then based on what they submit, deciding whether to accept them or not. So we may or may not have more people coming in. Actually, we had somebody come in and then leave. So I don't know what that was about. Anyway, for the people who are currently in here, I think I have a designation for each person. So those of you who are on the call, please continue your excellent work, Rob2ing it up. Any further inquiries before we end?
Yeah, since I just got approved, who would I pair with? And would I be doing like another record for next week?
Honestly, I think Ahmad is the next closest to getting approved. Yes, in fact, I will separate his category. Next closest to getting approved. So it's probably going to be him. I just only need to confirm with him that he has watched this video, and then he will be your partner. How about
Okay.
that?
Sounds good.
So when this ends, Zoom should email me, and then I can put it up. Hopefully it doesn't, like, I don't know, get deleted or whatever. All right, any other questions? Y'all did so good. I'm so proud of you.
I don't have any other questions.
Yeah,
Very good. Excellent work. You guys are on fire. All stars. Genius level. Love it. Keep up the good work. Great job.
Thank you.
Thank you.
Thank you, Dr. Waggle.
Yep. Bye.
Bye.
Abigail, you're the leader. You can just hit the X button and then I think it'll send me the recording.
Okay, perfect. Bye, Dr. Waggle.